Hello, welcome to the presentation of this case study on difficult to manage asthma. This session was developed by the Asthma Right Care Movement, an initiative of the International Primary Care Respiratory Group. My name is Jaime Correia de Souza and I am a family physician from Portugal. And this case study was created for you together with Dr. Katarina Stavric, a primary care physician from North Macedonia. The desktop helper number 2 focuses on difficult to manage asthma and provides a practical guide to improve the management of people with difficult to manage asthma in primary care. The IPCRG desktop helpers are practical guides to be used by busy clinicians in their daily practice. This guide provides a summary of the key points to consider when dealing with a person with asthma where either the patient or their clinician is finding it difficult to control and manage, despite what appears to be the best possible treatment. This guide provides practical support to primary care and other community healthcare professionals to improve the care of people with difficult to manage asthma and to avoid unnecessary referrals of patients who could be better managed in primary care. We will be speaking about how to identify a person with difficult to manage asthma, ensuring that the diagnosis is correct, and finding and managing comorbidities, and what should you check when conducting a structure review. This desktop helper can be accessed in the URL you can see in the bottom of the page. Let me start by introducing Alice. She attends a scheduled appointment accompanied by her mother with worry that her asthma is not well. During the last 2 months, Alice has had some days with wheezing and breathlessness during the night and while playing basketball. She has been well for a long time, but recently started feeling these symptoms again. What factors are hindering the control and treatment of this patient? Is this really a case of difficult to manage asthma? In this slide, you can see the learning objectives for the case study. At the end of this case study exercise, the participant should be able to list and recognize some of the challenges in asthma management, analyze and evaluate the impact of the patient's clinical history and consider the patient's own beliefs and preconceptions in asthma management, plan and carry out periodical reviews of patients with symptoms of wheezing and breathlessness, promote medication adherence and support self-management. On this first consultation with Alice, we need to know a little more about her. Alice is a 14-year-old from a family of 4. Her father is 40, her mother 38, and she has an 11-year-old brother. Her father works in an insurance company and her mother is a shop manager. The family is fairly health conscious in what regards diet and exercise. They often discuss this subject at home and with friends and encourage their children to keep fit and healthy by practicing sports and other outdoor activities. Nobody smokes at home and never did. Most of Alice's friends are also non-smokers as she mostly meets people with an interest in sports. Alice plays basketball at school and in the local team. She trains it 3 times a week and occasionally has games during weekends. We have met Alice and we will be learning more about her later. Right now, we need to consider what we should check when conducting a structural asthma review. First, we need to verify asthma control using one of the available questionnaires such as ACT, ACQ, CARAT, or others. It is mandatory to inquire about tobacco dependence or second-hand exposure to smoke. Don't forget to also consider exposure to biomass or industrial fuels, bad indoor or outdoor air quality, or any form of polluted environment. Patient education and self-monitoring are very important components of good asthma care. The more patients know about their asthma, the more enabled they are to take care of their condition and to be able to recognize and deal with the normal daily variations of symptoms, as well as to recognize when their asthma is out of control. Self-monitoring with the help of a symptoms questionnaire or a peak flow meter, as well as the use of an asthma action plan, also play an important part in good asthma care. It is important that patients are able to recognize aggravating factors and triggers and act to prevent exposure or to control symptoms. In what concerns pharmacotherapy, here we need to consider the choice of the adequate treatment and inhalers, which are essential. Physicians need to decide together with the patients on the choice of inhaler and the suitable treatment dose and frequency. Patients need to be made aware of the need to use maintenance treatment and how to recognize and manage side effects. Adherence to treatment and a correct inhaler technique are crucial to a good outcome in asthma control. Obesity, when present, needs to be dealt with as an important comorbidity and a possible aggravating factor for asthma symptoms. Psychological support is often required when persons with asthma have to deal with a long-lasting, sometimes incapacitating condition affecting their autonomy and lifestyle. Referral for specialist assessment should be considered when the physician and the patient recognize they have done what is feasible in a primary care setting and the patient needs to be evaluated by an asthma specialist for further investigation and to consider other treatments only available in secondary care, such as biologicals. Now returning to Alice's case study, we need to know more about her medical history. She was diagnosed with asthma by her GP when she was 8 years old because she had frequent episodes of wheezing, breathlessness, and occasional coughing when she had colds or in spring. Alice reports allergies to house dust mites and grass pollen. 2 years ago, she had blood and skin prick tests which confirmed sensitization. According to her mother, she also had lung function tests which confirmed asthma. Since her asthma was diagnosed and treatment started, Alice has been quite well with a few rare episodes related to viral infections. She has never been admitted to hospital, apart from a couple of times in her childhood when she went to an emergency department twice with asthma exacerbation. Alice's parents are well. No other members of the household have asthma or allergies. Her aunt, her father's sister, and one of her maternal cousins have asthma, and her grandfather, her father's father, has allergic rhinitis. The family lives in a modern house and have no pets at home. Her only regularly prescribed medication is her asthma medicine. She has been prescribed a low-dose ICS twice daily, and she has been advised to take 2 puffs of SABA before exercise. She doesn't take any medication for her occasional nose symptoms, which seldom bother her if she avoids dusty rooms. In spring, she sometimes needs an oral antihistamine for a few days. Now, coming to our current presentation. As her family physician, you know Alice and her family for a long time, as they have been attending your practice over time. Alice had an appointment with you for an asthma review approximately a year ago and with practice nurse 6 months ago. Considering control of asthma, Alice reports a good asthma control. Nevertheless, her answers in the asthma control test, ACT, led to a score of 19 corresponding to poorly controlled asthma. Now about tobacco, Alice is a non-smoker. Her closest friends don't smoke, though sometimes she meets friends who do. Concerning patient education and self-monitoring, we know that the nurse checked her inhaler technique prior to the appointment. Alice is able to use her inhaler correctly. She has been taking extra SABA, salbutamol, when she experiences symptoms such as wheezing or breathlessness, approximately once a week or occasionally before doing sports as advised. Here is the score of the asthma control test according to Alice's self-perception of symptoms. Considering aggravating factors and triggers, Alice notices a worsening of symptoms like running nose and slight wheeze whenever she's exposed to dust while visiting some friends who have old sofas or old books at home. In spring, when people are mowing lawns near her home, she also feels worse. She has a history of allergy to house dust mites and grass pollen. Looking at pharmacotherapy, Alice has been prescribed inhaled budesonide 200 micrograms in dry powder inhaler twice a day, plus inhaled salbutamol as needed in PMDI. Looking at adherence and inhaler technique, Alice reports she doesn't always use her ICS as recommended. She rarely uses it twice a day and often forgets or decides not to use it if she doesn't have any relevant symptoms. When she has wheezing or feels breathless, she uses her SABA rescue inhaler. Though she has been advised to take 2 puffs of SABA before exercise, she seldom does it because she feels her heartbeat increasing. She's able to use her inhaler correctly. Concerning obesity, Alice is in the normal range of BMI. Now looking at psychological support, Alice is worried as her physical performance is not the same and this is interfering with her playing basketball. This could be the main drive for change as she is very keen on being part of the team. While exploring Alice's health beliefs and preconceptions, we note that she is not happy to have to use an inhaler every day. Some of her colleagues who have asthma tell her that inhalers can be harmful. She has been looking at some sites and she also read that regular treatment is important. She doesn't know what to believe. She is also concerned that it can impact on her performance in basketball. Looking at refer for specialist assessment, we think that it is not relevant at this point. Now we need to provide some information on clinical examination, and here are the main findings. Alice's heart and lung sounds are normal. Her pulse rate is 80. The latest spirometry results were normal. It was done 2 years ago. Her peak flow was 330 liters per minute and it was done today. Alice's height is 165 centimeters. Her expected peak flow is 445, so she has 74%. And her best recorded peak flow was 450. This means today she has 73% of her best. So the question is, how would you evaluate these findings? So the conclusion concerning clinical examination is that the chest exam was unremarkable. Alice's peak flow was 73% of her best. Adherence seems to be a point for discussion. So what should be the next management steps? Now we should discuss management. So what are the next steps? Let's look at adherence. We ask her opinion about use of inhalers. How comfortable does she feel with the one she has? Are there any unpleasant side effects? Are there any other issues with the inhaler? We explain her that many people forget doses and that's quite normal, but perhaps she would do better if she'd use reminders, such as phone alarm, to help her remembering to take it, as she's having symptoms and not feeling so well as she'd like to. We have to consider possible treatment change. We explain it is possible to use a control and a reliever in the same inhaler device. That helps because when she takes a puff to relieve her symptoms, she is also using a medicine that treats her asthma. Furthermore, she's using two different devices with different inhaling techniques. Alice prefers to try again with the same treatment but trying to remember the doses. So we agreed to have a new appointment to review the situation in 4 weeks' time. So Alice returns to the practice 4 weeks later. She informs she has been using a phone alarm and she has been able to remember to take her inhaler regularly. She has been feeling better. She had a slight wheeze less than once a week and used her reliever inhaler and felt better. She feels she needs to have the blue inhaler, but she doesn't like the effect on her heartbeat while she's doing sports. She also confirms it's a bit confusing to use two different types of inhalers, dry powder inhaler for control and PEMDI for symptom relief. The findings from today is that her ACT score is 22, well-controlled asthma. Her peak flow reading at the practice was 370 liters per minute, so 82% of her best. Playing basketball has no impact. So, considering the patient information, the clinical examination, and the investigation, what is your conclusion so far? Please take a moment to think about this case study. What is your conclusion? You conclude that Alice's symptoms were mostly due to irregular adherence to medication. Occasional secondhand exposure to cigarette smoke doesn't seem to be a problem as it is rare and for a limited time. Most of Alice's friends are practicing sports and don't smoke. Alice is still insecure about using medication before exercise. She doesn't like the secondary effect of the SABA. Using two different types of inhalers is confusing. A choice of an ICS formoterol inhaler could be considered, MART. Though the secondary effect might be similar, increased heartbeat, she could do it a couple of hours before starting her basketball training. So what are your next management steps? You initiate a conversation about Alice's fears and concerns regarding medication. You offer advice and recommend some websites for further information. Together with Alice, you decide to switch to an ICS formoterol inhaler, budesonide 160 micrograms with formoterol 4.5 microgram on dry powder inhaler on a MART regimen. You suggest she tries using the inhaler before exercising and see if it really makes a difference. You suggest the use of an app to record symptoms over time. You tell Alice to come back for a review after 3-4 months. This is a slide with a reminder of the GINA treatment steps. Note the MART regimen for steps 3 and above. Alice should be placed in treatment step 3 using a low-dose maintenance and reliever therapy using an ICS formoterol containing device, in this case with a dry powder inhaler. So 3 months later, Alice comes for another appointment. You conduct a new structured review, keeping in mind the previous steps, but focusing on 4 main elements: the control of asthma, patient education and self-monitoring, aggravating factors and triggers, and adherence and inhaler technique. We need to review the patient's information, clinical examination, and investigations from the third consultation. Alice informed us she has been using her inhaler regularly and she has been feeling much better. She had a little wheezing and cough once when she had a small viral infection. She increased the number of puffs of ICS formoterol and felt better. She thinks the MART regimen is very easy and fits well in her daily schedule. The app was used and it was useful to help her understanding the relationship between adherence and symptoms. The websites she consulted helped her understanding her asthma better. Alice's ACT score was 25. The peak flow measurement was 400 liters per minute, which corresponds to 89% of Alice's best. So, what is your conclusion so far, and what will be your next steps? Considering the management of Alice's asthma, the next step should be: Alice seems to be well controlled and more aware of the importance of the regular use of the treatment. She is happy that the MART regimen gives her some flexibility and she feels more enabled to self-manage her condition. The mother is relieved that Alice is doing well and trusts her to take care of her own symptoms and to report if something is wrong. We discuss whether she would like to have a written asthma management plan, but Alice prefers to use the app. Nevertheless, a plan was handed to the mother as she revealed she would feel more confident as a parent but also as a reminder. The plan also contains clear instructions of what to do in case of asthma exacerbation. This is an example of written asthma management plan. You tell Alice it would be useful if she would return in 6 to 9 months or before if she needs to. You let her know she can call the practice to speak with you, the practice nurse or any other GP if anything feels wrong about her asthma. So, in summary, adherence is an important issue in achieving asthma control. Many patients forget or skip doses when they feel better. An open-minded, non-judgmental interview using the right questions might help identifying poor adherence. A MART regimen can be useful to deal with symptom variation and difficulties with adherence. Patient enablement and the promotion of self-management is an important step to achieve asthma control and patient well-being. Structured care and periodical asthma reviews are important to support patients and to ensure that asthma right care is provided. So this is what good quality asthma care looks like. You can scan the QR code in the right lower corner to learn more about asthma right care and our consensus definition of a good quality asthma care. So we are coming to the end of the presentation. If you wish to know more about Desktop Helper, please use QR code in this slide. And thank you for listening to the presentation.